Okay, so I'm hoping that we can get through this chapter in an hour, unlike chapter 9, which took 3-hour segments. It shouldn't take too long, especially because it's going to be more of something that you'll learn about in lab. So I don't know if Justin already had you guys do finger sticks yet, but if not, you guys will be doing them when you come back. So let's get started. Okay, so capillary puncture is basically just making an incision in the skin rather than going directly into a vein and obtaining like a venous blood specimen or into an artery and obtaining an arterial specimen. You're just puncturing the capillary beds in the skin, so you're actually going to get a capillary blood specimen. So can anybody tell me what capillary blood is? We did talk about it. I think it was chapter 6 that we talked about capillary blood. So basically, it's a mixture of arterial and venous and capillary blood. So capillary blood is a mixture of arterial and venous blood because it's where your arteries go into your arterioles from your heart, and then that goes into your capillaries where oxygen and carbon dioxide is exchanged in the capillary beds, and then through the capillaries to your venules and to your veins. So it's actually a mixture of the two types of blood. It more closely resembles arterial blood. That's because the blood coming in is under more pressure than the blood coming out of the capillary beds. So keep that in mind. It is a mixture of arterial and venous blood, but it is also closely resembles arterial blood. So in order to do this, in order to puncture the capillary bed or create an incision in the skin, we have devices rather than using needles like we do for a venipuncture or an ABG or arterial specimen. We use what are called lancets. These are sterile, disposable, sharp-pointed or bladed instruments that puncture or cut the skin to obtain capillary blood. There's two different types of lancets. There's puncture lancets, which quite simply just create a puncture in the skin. They just poke a hole in the skin. There's also incision lancets that create a cut or an incision in the skin. So a puncture lancet would be like a needle poking into the skin. For example, when a diabetic is taking their blood sugar, that's just a sharp needle that pokes into their skin. They don't need much blood for those tests. Pocked glucose measurements. So remember in chapter 11, there were all those pocked instruments that we talked about that didn't talk about because we don't do point of care testing. When they do like glucose measurements and stuff like that, some PT INRs can be done via finger poke. So those are going to be needles that just basically puncture into the skin real quick and come back out. When we are doing blood collection via capillary puncture, it's most likely going to be an incision lancet. So this is actually a blade that cuts the skin, and that enables us to get more blood out of that incision rather than the puncture, where the blood is most likely going to clot before we can collect it. So those are the two different types. And when we're collecting capillary specimen, we don't collect them into the regular vacuum tubes that we would with a venipuncture. We have these what they're called microtainers or microtubes that we actually just drop the blood into. They're small plastic tubes used to collect tiny amounts of blood from capillary punctures. Some come with narrow capillary tubes attached. They are color-coded, so the caps of these are color-coded, just like your regular venipuncture ETS tubes. However, they don't have a vacuum, so you open it and you're actually dripping the blood from the incision into these tubes. Something that I would like to say about these tubes is you never want to overfill them. So with your vacuum tube, you don't have you don't have the possibility of overfilling them unless you're squirting a syringe into them, because the vacuum will automatically exhaust. With these, you can overfill them, and if you overfill them, then the additive to blood ratio is going to be off, and you're going to have, like, in your anti-coag tube, so this lavender, your blood shouldn't clot in here. If you overfill it, there's not going to be enough anticoagulant to keep the blood from clotting, and you will actually get little microclots, and the specimen will be no good. So you have to be very cautious that you're not underfilling and you're not overfilling. So this is your minimum fill line and this is your maximum fill line. Don't go below this line and don't go above this line. So I would suggest just trying to get right below this max line. This is one example of a microtainer. We used to have these ones, and I personally like the newer ones better. I know Justin likes these ones better, but with these ones, they have a rounded bottom, so you have to hold the tube in your hand the entire time. The newer ones, let's see, these ones are the newer ones, and they have a flat bottom, so you can actually set them down partway through the draw if you need to. That's why I like them better. They also come amber coated, so when you're doing things like bilirubin draw or folate, B12, stuff like that, anything that needs to be protected from light, they have these microtainers that are actually coated in an amber colored coating, so you don't have to protect them from light. They're automatically protected in these tubes. When we're gonna show you now. Okay, I'm getting ahead of myself, sorry. So these are examples of some Lancets. These ones are going to be like the needle puncture devices, and then these ones are going to be more like the incision devices where they actually cut in your skin. Something that is important to note is that you will never actually see the blade or the needle because it will automatically suck back into the device. So unless you break these open, you're not ever going to see the needle or the blade. So you take this off. Basically, you take this cap off right here. The blade or the needle is still inside of here, and then you press this tip. Once you've removed this, you press this tip on the finger or the heel, and that causes like a spring to react and puncture or slice, and then it retracts right away. And then what are you going to do with these when you're done with your heel stick or finger poke? They're going to go in the sharps container, okay? I've seen a handful of times where phlebotomists will grab them in their gloves with their tourniquet and all their other garbage and just throw them in the trash. Nope. You can't see the puncture or device or the blade, but it's there and it's still considered a sharp, so it goes in the sharps container, okay? These are examples of what we would use for heel sticks. They're a little bit more aggressive than the finger poke because the skin in the heel is a little bit thicker. So each of these has like a different depth or length of the blade. And these are all incision devices. None of these are puncture devices. Like I said, pretty much anything that we're going to be using is going to be an incision device. So this white colored one is for like premature babies. They're the most shallow. They go in, the length of the blade is 1.75 millimeters, and they go in about 0.85 millimeters. You're most commonly going to see this blue one, which is the length is between that of the white and the pink. So the pink is like the most aggressive. You would use this on more older patients, not, I wouldn't say toddlers, because if they're walking, you should not be doing a heel stick on them. But the depth of this is 2 millimeters. So between 8.85 millimeters and 2 millimeters, that's going to be your blue one. I searched on the packaging for the actual depth, and I'm not gonna expect you guys to memorize like the depth that they go in, but I searched for the depth, and for some reason on none of the packaging on the blue does it tell me what the actual depth is. The white and the pink, it does. So I don't know, it's somewhere between. Just remember that The white is used for premature babies. It's the shallowest depth. The blue's in the middle, and then the pink is the most aggressive. It goes the deepest. You're never going to want to puncture a heel more than 2 millimeters because that is risking nicking the bone, and it can cause bone damage actually in toddlers or infants. This is a different example. These are the ones that we have here. They're the most common. I've never seen one like this, but this one you basically push that little white button and that triggers it. With these ones, you are going to actually pull this. This is like a additional safety feature of it. You pull this tab off, like it comes completely off, and then this becomes a button that you push in. I don't think this one has that additional safety feature, and I think that's why these are more common. These have a tendency to probably go off accidentally if you're keeping them in your trays or carts. So these ones, they're Tenderfoots. That's the brand. Okay, we just talked about these. I honestly don't exactly know what these ones are. I've never seen them, but this looks like a capillary tube. So basically, instead of dropping it right into the tube, so this cap here comes off and you just drop the blood right into the tube. With these ones, I think that it's a little bit more sterile because you're dripping it into this capillary tube that then goes into here. So you don't have as big of an opening. But I'm not sure what this is, really. These are going to be your most common microtainers. Okay. So then we have, this is another way to collect a capillary specimen. These are usually used for capillary blood gases, which test respiratory functioning in newborns, and patients where arterial puncture might not be an option. So those that don't have good collateral circulation, maybe they'll do a capillary blood gas rather than an arterial blood gas. So this is what's used for those. They are disposable narrow bore plastic or plastic clad glass tubes. I will have Justin show you guys how to perform one of these in lab when we get back, because it's a lot easier to, it's hard to explain. It's easier to explain while you guys are watching it being done. But these tubes fill by capillary action. So you just touch it to the drop of blood and the tube will actually suck it in itself. It's hard to explain, but you'll see it when he does it in lab. Going more into depth on this, in order to collect a capillary blood gas specimen, you're going to need your collection tubes, which you just saw. These are your collection tubes. And then they come in different sizes, and they're normally coated on the inside with heparin so that the blood won't clot. But as well as that, you're going to have plastic caps used to seal the tubes. So when you collect a capillary specimen, you're going to have one cap on the end, and you're going to drop the blood onto this side, and it will fill itself by capillary action. And then once you have that narrow bore capillary tube filled with blood, and first of all, you want to make sure that there's no air bubbles in there at all. If there's air bubbles, you're going to have to recollect, because what are we testing with capillaries blood gases or arterial blood gases? Respiratory functioning, which oxygen has an effect on those test results. So we don't want any air in those tubes. So then once you have that filled and you make sure there's no air in the tube, you're going to put one of these metal stirrers in. So they're tiny little metal bars that fit right inside of these tubes, and you're going to place one inside of the tube. They're designed to mix the anticoagulant with the blood. So you put that in there, and then you cap the other side of the tube. And then we have these magnets that are used in conjunction with that stirrer. So that metal stirrer is a magnet as well as an external magnet that we actually slide from one side to the other to move that stirrer through the tubing and mix the blood and anticoagulant. Okay, so like I said, I know it's confusing when it's explained to you this way, but when you see it, this will all make so much more sense. Do not worry about microscope slides. Our hematologists are the ones that will do this. I don't know of any phlebotomist anywhere that has to carry microscope slides to perform a blood film or blood smear. Warming devices, however, this is huge. So before you do a heel stick or a finger poke, warming devices, I guess you don't have to use them. However, I highly suggest it. It's going to increase the blood flow to that area so much. If you don't do it, the blood is not going to be forming a nice plump drop. It's going to be difficult. If you're squeezing that site, you're going to get tissue fluid contamination. It's going to come back with erroneous test results. You're going to have to go back up and redo it. So a warming device is highly recommended. It says here it increases blood flow as much as 7 times to that site. So you will actually find, so like if I have to go up to the, to do a heel stick on an infant, I'll normally call up to the OBGYN and say, hey, can you throw a heel warmer on that baby for me so that while I'm walking up there, that heel warmer is on that heel, warming that heel up so that I'm going to get a really nice blood flow when I go to poke the baby. So here is a picture of your capillary blood gas collection equipment. These are actually arterial blood gas syringes, so don't worry about these. Our respiratory therapist will be dealing with these, but this is like the complete setup. So you've got your caps on either end. These are your metal stir bars, and then this little magnet, you're going to line up with the stir and move the stir up and down the tube to mix the anticoagulant with the blood. You're going to make sure that there's no air bubbles in there. And then, like I said, that narrow bore or clad tube is going to be lined with heparin to keep the blood from clotting. Okay, we talked about the composition already, so it's a mixture of arterial, venous, and capillary blood. There's also some interstitial and intercellular fluid in there, so we're going to go through in a minute, I think, which tests cannot be collected by capillary puncture. So I won't get into that right now, but there are different reference values. So we talked about the reference ranges for a venous specimen. There's different reference ranges for capillary specimens. Then they just give a couple of examples. I'm not going to expect you to know these off the top of your head for your exam or anything, but I'm going to just mention them. So glucose concentrations are higher in capillary blood. Total protein, calcium, and potassium concentration are lower in capillary blood. So just be aware that your reference ranges are going to be different for capillary blood, as well as for arterial blood and venous blood. So all the different types of blood in your bloodstream, they're going to have different reference ranges. Okay, so how do you know when you should do capillary puncture rather than a venipuncture? So if the veins that you have available are fragile or must be saved for other procedures. So if you've tried and had several unsuccessful venipunctures and you just cannot get it, you've got another phlebotomist, they've tried multiple times and cannot get it, a capillary puncture may be your best option, as long as it's not one of the tests that cannot be performed via capillary puncture, which we're going to talk about in the next slide, or not the next slide, but the following. If the patient has clot-forming tendencies, if the patient is apprehensive or has an intense fear of needles, this might be a better option. In my opinion, I'd rather just have a venipuncture than the finger poke, because the finger poke hurts for days afterwards, but some people would much rather have a finger poke. It's not the pain that bothers them, it's the needle, and since you cannot see the needle at any time during a finger stick, that may be a better option. If there are no accessible veins, such as burns, there's scars, there's IVs in both arms that are unable to be shut off for venipuncture, this may be your only option. I don't know if there's anything else I want to say about that, but I swear there was something else I want to say about that. But if I remember it, I'll come back to it. And then for point of care testing procedures, so like I said, with like your glucose monitoring for diabetics and stuff like that, these aren't going to be incision devices. They're going to be puncture devices that are used for those. But that is another reason for a capillary puncture. We won't ever have to do a POCT procedure like glucose monitoring. That'll be the nurses or medical assistants. But just know that that is one of the uses for a capillary puncture. So in infants and young children, if they have a small blood volume or risk of anemia, so in small children or infants, all of your blood draws are going to be heel sticks. You should not perform a capillary puncture on a finger of a child that's younger than a year because you're risking injuring their bone. Their fingers are so tiny, there's not a lot of skin and tissue between that and their bone. Or if there's a risk of cardiac arrest when large quantities of blood are removed. If the venipuncture is really difficult and may damage veins or surrounding tissues, so on really young kids, maybe a finger stick might be a better option, depending on what tests are ordered. If puncturing deep veins can cause hemorrhage, venous thrombosis, infections, or gangrene, so gangrene is basically like dying tissue. Or if the risk of the injury due to restraint needed for venipuncture is too great. So some kids will fight till the end, and maybe venipuncture isn't a possibility because of the restraint needed. So a finger stick might be a better option. Or there are some tests where capillary blood is actually preferred. I don't think I wrote down. Oh, so newborn screening, this would be one example of that. So newborn screening is also called PKU, and we're going to talk, I think that's the last slide in here, we'll talk about newborn screening tests. So basically, I'll just kind of give you a background. Newborn screening is, they're testing for certain disorders, and they can be determined at birth even if the infant isn't showing any signs or symptoms of them. So, and it's actually required by law that every newborn child has a PKU done in the first 24 hours of birth. So, that is one example of a test where a capillary specimen is preferred. Okay, so now we're going to talk about tests that cannot be collected by capillary puncture, and I want you guys to star this slide, memorize it. This will be on your exam. This is something that you need to know. If you collect any of these specimens via capillary puncture and bring them back to a lab tech, they are going to laugh in your face, okay? Basic phlebotomy, no. Okay, so you cannot collect erythrocyte sedimentation rates or coagulation studies or blood cultures or tests that require large volumes of serum or plasma. So, when you puncture the skin, it actually releases thromboplastin. Do you remember what thromboplastin is, or thrombin? It's basically an enzyme that initiates clotting. So specimens that must be collected quickly, or specimens that are collected via capillary puncture should be collected quickly in order to prevent this. And then tests that are most affected by clotting processes, such as coags. So your coagulation studies are testing for clotting. They cannot be collected via capillary puncture. Okay? So, with this being said as well, sorry for that pause there. With this being said as well, your order of draw is going to be kind of backwards for capillary puncture, okay? So remember that. Your normal order of draw for venipuncture is going to be backwards. With that thromboplastin that initiates clotting that is released when you puncture the skin, tests that are most affected by the clotting process, like I said, coags are not going to be collected, but hematology tests are also pretty affected by the clotting process, should be collected first, and then those that are required to clot, such as your serum specimens, should be collected last. Okay, so in this, we're going to talk more about that. So, like I said, your order of draw is opposite that of your regular order of draw due to the release of tissue thromboplastin, which occurs after puncturing the skin and initiates clotting. So your blood gas specimens are going to be the first thing you collect, then your EDTA specimens, then your plasma or any other specimens, your serum specimens are going to be collected last, okay? And that's because that initiation of clotting is going to, you want to collect your hematology specimens first that are most affected by that clotting, and then your serum specimens can be collected last because they're going to be clotted anyways. Okay, I hope I explained that well enough. I might come back to it at the end and kind of go over it again. Okay, sorry, I had to make sure I was in the right spot here. Thought I was missing a slide. Okay, so I'm going to try to find a video on a general capillary puncture and post it separately. But you guys will also, if Justin has not already shown you how to do this and had you guys practice on each other, he will in the upcoming labs. So I'm just going to read through the steps. It's pretty much the same as a normal venipuncture up until the actual puncture and procedure after that. So you're going to receive, review, and accession your test request. You're going to approach, greet, and identify your patient, explain the procedure, make sure that they consent to the procedure. You're going to make sure you look at all the collection requirements, identify any sensitivities or potential problems. So if it needs to be protected from light, if it needs to be put on ice, if it's a coag or a blood culture, you're not going to collect it via capillary puncture. It's not an option. Anything else? If your patient has any allergies, this would be the time to do it. Then you're going to sanitize your hands, put your gloves on. You're going to position the patient. So you're going to want, it's going to be really hard for me to explain how you want to position your patient, but they say you want the arm supported on a firm surface and the hand extended and palm up. Actually, what I like to do is I like to have their arm kind of hanging down next to them. That kind of helps gravity, or has gravity help in the process of collection. If it's a young child, you're going to have them held in the lap of a parent or guardian. I've actually never done a finger stick on a child. Lots of heel sticks on infants, but never a finger or capillary puncture on a child. Generally, I would say venipuncture is easier because you can get the specimen quicker. Capillary punctures tend to take a little bit more time. And then with your infant heel puncture, so what I do is I wrap the baby up in a blanket and just have the one heel that I'm gonna puncture sticking out of that blanket, and I make sure that it's nice and tight so that their arms can't get out and their other leg can't get out. You don't want that other leg out flailing because they're gonna kick at their other heel and try to get you to stop doing what you're doing, and that's going to get blood everywhere. You might drop the capillary collection tube. So I just really like to wrap them up tight. Obviously not too tight, but wrap them up tight so that they can't interfere with what I'm doing. Okay, and then you're going to select the puncture site. So there are some general criteria for this. You want to make sure that the skin is warm, pink, and a normal color. So like I said, you want to use your heel warming device, or if their fingers are really cold, I would definitely use a heel warmer on their fingers. Maybe run it under some warm water. Make sure that there's no scars or cuts, bruises, rashes. Cyanosis would be like a bluish hue to the skin. Edema would be like swelling of the finger or any infection. Or if there's a previous puncture there from a previous heel stick or finger stick, you obviously don't want to go for the same spot. So for adults and older children, when you're doing a finger stick, you're going to want to use the palmar surface of the distal or end segment of your middle or ring finger of your non-dominant hand. Okay, so important parts of that sentence. Non-dominant hand and the middle or the ring finger. You're not going to use their pointer finger, you're not going to use their pinky, and you're not going to use their thumb, okay? The reason that you're going to use their non-dominant hand is because it's typically less calloused and easier to puncture than their dominant hand. You're not going to use their pointer finger because they use or their thumb because they use those a lot, okay? You don't want to interfere with that. You're not going to use the pinky because there's not a lot of tissue between that exterior and the bone. So the ring finger and the middle finger are your best option. And you want to go for the central fleshy portion of the finger. And something that I would like to mention is that you want to go against the whorls of the fingerprint. So if you look at your fingerprint, you can see the direction the whorls are going. You don't want to go with those lines in the skin, okay? So the fingerprints. You don't want to go with the fingerprint. You want to go against it. And the reason that you want to do that is because if you puncture with the whorls of the fingerprint, or same with your heel, same with the heel of an infant, if you go with the whorls, that blood is actually going to drip and follow the grooves and run down the finger or heel, and it's going to make it really difficult to draw. It's going to make it really messy. You're not going to get a nice plump droplet of blood that will drop right into your collection container, and it's going to make you want to scoop or scrape the blood into the collection container, and as we're going to talk about in a minute here, that is not an option. You don't ever want to scoop. You want to let that plump droplet of blood drop directly into the blood container. So I'll just talk about it now. Scooping or scraping the blood can actually activate platelets and cause them to clump. So if they clump, then they cannot be analyzed. It can also cause hemolysis of the specimen, and it can contaminate your specimen with tissue fluid or bacteria on the surface of the skin. So you always want to allow the blood to drop into the microtainer without touching the microtainer to the skin. You're never touching the microtainer to the skin. You can touch the microtainer to the droplet of blood, but not to the skin. What else am I going to say about that? I think that's it. That's all I'm going to say about that. Okay. So go against the whorls of the fingerprint. Okay, so in infants, like I said, finger puncture, infants 6 to 12 months and less than 10 kilograms, they have lancets specifically developed to penetrate less than 1 millimeter. So that would be those white lancets that I showed you. Heel puncture, you're going to want to go on the plantar surface, on the medial or lateral edge to avoid bone damage. So you don't want to go right in the center of the heel. And there's a good picture on page 312. That shows you in the pink shaded area where it's okay to perform a heel stick. Don't go on the side of the heel. You want it to be fleshy, but not right directly in the middle of the heel. So follow the picture on 312 in that shaded area. That's a really good picture to show you where you can puncture in the heel. Okay. So here's a cross section of a full-term infant's heel. So this shows the depth that the lancet goes into the capillary bed. So this would be a little bit further than 1 millimeter down into the capillary bed. So from there, see all these little capillary blood vessels in here. That's what's going to bleed onto the surface of the skin. It's going to form a nice plump droplet. But picture this upside down because you want gravity to help you. So you want the droplet to be coming right here, and you're just going to be holding your capillary tube underneath that droplet. I wish I could draw it for you. Okay, so here's the recommended site and direction. So middle or ring finger on non-dominant hand, and you want to go, like I said, against the fingerprint, not with it, okay? Same with your heel. So you want it on the medial You want it on the outside parts. In other words, you want it on the outside parts of the heel, not in the middle, but you also don't want it to go up towards the heel or the ankle. You want to stay in the fleshy bottom part, the plantar surface, so the bottom surface of the heel. You're never going to poke anywhere up here. It's only going to be in the heel section, okay? I have written, there's a couple good charts. Table 10.2 in your book on page 311 gives you finger puncture precautions. So you don't want to puncture the fingers of infants and children under 1 year of age. You do not puncture fingers on the same side as a mastectomy. So that's the same as with a venipuncture. You do not puncture parallel to the grooves or lines of the fingerprint. So that just makes the draw a lot more difficult if you do. Don't puncture the fifth or pinky finger. The tissue between the skin surface and bone is thinnest, so bone injury is likely to occur. Don't puncture the side or very tip of the finger. Same reason as why you don't puncture the little pinky finger. The distance between the skin surface and bone is half as much as on the side of the fingers. Don't puncture the index finger. It's usually more calloused. It's harder to puncture. It's more sensitive. The puncture can be painful because it's used more. And don't puncture the thumb. It has a pulse, so there's a larger artery. The skin is generally thicker and more calloused as it's used more often. It might be more painful for the patient. Same with the index finger. So that's a really good finger precaution table there. On page 312, there's a really good table for heel puncture precautions. Table 10.3 at the bottom. Don't puncture any deeper than 2 millimeters. We talked about that. This risks injuring the bone. You don't want to puncture areas between those imaginary boundaries right here. And why is that? Because the calcaneus or heel bone can be, it's a lot shallower in this area. The area of skin or tissue tissue between the bone and the skin is a lot less than it is on the sides here. You never want to puncture bruised areas. You don't want to puncture in the arch or up here like we talked about. You never want to puncture in the same site as a previous puncture. You don't want to puncture in areas that are swollen. So those are really great charts on precautions when doing capillary punctures. Okay, so step 8. So this would be, we've gotten through the main preparatory part of the draw. Now we're actually getting into the puncture. So you're going to warm the site. Like I said, 5 minutes. If you've got 5 minutes to warm that site, that's going to be prime. So it increases the blood flow to that area up to 7-fold. It's essential for pH or blood gas specimens, and it's recommended for heel sticks, like I said. 3 to 5 minutes. If you don't have a heel warmer, you can use a warm, moist washcloth, towel, or like a diaper not obviously a used diaper, but if you have nothing else to use, I guarantee you're going to have heel warmers wherever you go, but they're just kind of getting into other options if you don't. So then you're going to always clean and air dry the site. So you're going to wipe wherever you're going to poke with your alcohol swab, allow it to air dry. Then you're going to, whenever you're dealing with a child, you are going to have gloves on for this entire process. There's no reason that you should not. If you're doing a finger poke and you don't already have gloves on, this would be the time you do it. Granted, you should have gloves on during this whole procedure. You're going to select whichever Lancet you're going to use. Place it easy to reach, and then open the packages of the Lancet in view of the patient or infant. Many times you're going to be drawing an infant in front of the parents. Okay, then you're going to grasp the finger or heel firmly. I cannot show you how I grasp the finger or heel, seeing as I'm not in person with you, but I will show you guys when we get back how I like to hold the heel, what works for me, and I believe it's the same way that Justin does. So then you're going to hold the Lancet between the thumb and index fingers of your dominant hand. grasp the patient's middle or ring finger, and then press down in order to initiate the puncture device. In heel sticks, you're going to grasp the foot gently, and then you're going to press the button on the side to get the lancet to come out and puncture the skin. So this is what I just said. Place the lancet flat against the skin, warn the patient of the poke, activate release mechanism to trigger puncture, remove device from skin, immediately discard it in sharps container. Lower the finger or heel, apply gentle pressure until blood drop forms. So you're not going to be milking the site, okay? You're going to apply enough pressure to form a blood droplet and then let the blood drop into the tube. But what we're going to do first is wipe away that first drop of blood. Why are we going to do this? So the first drop of blood is typically contaminated with tissue fluid. It can also contain alcohol residue. So if it's contaminated with tissue fluid, that's going to affect our test results. If it's contaminated with alcohol residue, that's going to hemolyze the specimen and it's going to be no good and we're going to have to go back and redo it. So you always wipe away the first drop, okay? So if you don't remember any of these other steps to a T, remember that you always wipe away the first drop and why. So then you're going to fill your tubes and containers in the correct order of draw for capillary puncture. Remember, it's opposite of a regular venipuncture. So you're going to fill your lavender tubes first. Then you're going to fill, first you're going to do if you have a capillary blood specimen, you're going to do that first. Then you're going to do your lavender tubes. Then you're going to do your plasma or other specimen tubes. Then you're going to do your serum specimens last. So opposite the regular collection of draw, or order of draw. Okay, and like I said before, you can touch the collection tube to the drop of blood, but you're never going to touch it to the skin. And why is that? Because it will contaminate it with tissue fluid, and that'll cause erroneous results. Then you're going to place the gauze, apply pressure, elevate the site, label and prepare specimens for handling and transport, check the site to make sure that it's not bleeding too much, and apply your bandage. Discard your used materials in the trash, thank your patient, remove your gloves, sanitize your hands, transport your specimen to the lab promptly. So pretty simple. When you see it actually done, it's going to be like, oh, that's not too bad at all. I think the hardest part is remembering that the order of draw is opposite and understanding why it's opposite. So I'm going to go back over that right now. Okay. So when you puncture the skin, it releases thromboplastin, okay? So that initiates clotting. Remember, thrombin is the enzyme that initiates the clotting process. So specimens must be collected quickly to prevent this, and tests that are most affected by the clotting process, such as your hematology tests, must be collected first. And those that are meant to clot, such as your serum specimens, must be collected last. So your EDTA specimens, then your plasma specimens, then your serum specimens. Before you even start with your regular order of draw, you collect your capillary blood gases if needed. Generally, when it's a capillary puncture, you're probably going to be doing like a bilirubin on a baby, maybe hemoglobin on an adult. Not often do we do capillary blood gases, but if we do capillary blood gases, they're most likely going to be on infants. Okay, so moving on, we're going to talk more now about the newborn screening and tests that we do on infants. Like I said, a common one is your neonatal bilirubin collection. So something that is important to note about this is when you're collecting a bilirubin specimen, if the baby is under the Billy light, so there's like a special light that they use to help babies break down the bilirubin that they have no production of. You are definitely going to want to turn off the Billy light when you're collecting the specimen. So if the Billy light is on when you're collecting the specimen, it's going to break down that bilirubin before testing is complete. So then you're going to get erroneous test results. You're not going to get accurate test results. So make sure that you're turning the light off. Like I talked about before, we have the amber colored microtainers, so we don't have to protect the specimen from light in transport. But if you are working at a facility that does not have those amber colored collection containers, you can use an amber colored bag. You can wrap it in Coban. You could use aluminum foil. You can put it in a glove, but I don't suggest doing that because there's a kind of a risk of accidentally throwing the glove away, forgetting that you put the specimen in there and throwing the glove in the trash. So be cautious with that. But anything you can use to protect it from light, you're going to want to do that. And then the newborn screening. Like I said, certain disorders can be determined at the time of birth, even though that infant may not show any signs or symptoms. So some of these would be phenylketonuria, hypothyroidism, galactosemia, cystic fibrosis. These are all things that they can test for 24 hours after a baby is born. They can determine whether they have this or not. And then this is an example of your newborn screening specimen collection kit. You can tell it's a little late at night. I'm starting to get tired. So anyways, these are mandated by law. They're called PKUs for short. We used to do these on every baby that was born. They are now having the nurses in the OBGYN collect these, which makes me really sad because I loved collecting these. These are like the funnest things to collect. They're difficult, but it's like a nice refresher from doing your venipuncture over and over every day, same thing every day. These are really kind of a fun change. But if they are not adequate, the baby will have to come back in and have these redone. So things that would what's the word I'm looking for? Things that would cause a PKU to be rejected would be if so basically what you do is instead of collecting the blood in a container, you will drop 1 to 2 drops of blood in the center of each of these dots, and you've got to fill each of these dots with that blood. Then the blood dries and is sent off to a testing facility where they test for these disorders. So if you have a blood drop that doesn't completely fill any one of these circles, it will be declined. If you have a really messy PKU where there's blood smeared all over this area and not just in the circles, it will be declined. If you have if you have a drop of blood in the circle and you get all the way to the end and then you come back and do it again, so you have layers of blood drops where this blood might be dry and then you come back later and drop another new drop of blood on that same spot, it can be declined for I'm trying to think of the word that they use. I wonder if it's in your book. Unfilled or incompletely filled circles can result in inability to perform all required tests. Circles must be filled from one side of the paper only and by one large drop that spreads throughout the circle. Application of multiple drops or filling circles from both sides of the paper causes a layering, that's the word I'm looking for, layering of blood and possible misinterpretation of results. And you never want to touch the baby's heel to this paper. You never want to touch your fingers to this paper. that can cause inadequate results. If you stack these before they're dry, that can obviously cause erroneous results, as the blood from the paper on top of this paper could leak onto this paper and just cause all sorts of issues. Hanging these rather than letting them sit to dry may cause the blood to migrate and concentrate towards the low end of the filter paper, so that can lead to erroneous test results. I don't know if there's anything else I want to say. Okay. So there's a really good procedure for newborn screening blood spot collections on page 327. But I'm gonna actually try to find a couple videos on capillary punctures and like collecting PKUs and stuff, and post them. I really hope that you guys get to see one of these done at externship. It's a lot easier to visualize when, well, I mean, obviously you visualize it better when you're watching it, but it'll make more sense. So I do kind of want to go into a little bit more depth on the types of diseases they screen for. So fetal ketonuria, this is where PKUs get their name. So phenylketonuria is a PKU. It's a disorder characterized by a defect in the enzyme that breaks down a certain amino acid. So without intervention, phenylalanine, which is in almost all food, accumulates in the blood and is only slowly metabolized by an alternate pathway that results in increased phenylketones in the urine. So it can't be cured, but it can normally be treated with a diet low in this phenylalanine. I don't expect you guys to know that. I just wanted to kind of briefly talk about it. Hypothyroidism is basically a disorder characterized by insufficient levels of thyroid hormones. Galactosemia is an inherited disorder characterized by the lack of an enzyme needed to convert milk into sugar. So, basically what the body needs for energy. And then cystic fibrosis is a genetic disorder caused by one or more mutations in the gene that directs a protein responsible for regulating the transport of chloride across cell membranes. So it basically causes mucus buildup in the lungs. And you can read more about it if you're interested. I'm not gonna test you guys on these diseases. I just kind of wanted to give you a little background on them. Okay. You are not going to do this. You can just cross this out. So don't even worry about the last two slides. You're not gonna do that. I'm not gonna test you on it. And that is that.